Go ahead. Yes, Terry.
Hi, I'm Terry Davis. Thank you. I loved listening to you. This comment or question is informed. My research assistant is a type 1 diabetic. She's 28. She was diagnosed at 14. And she gets so worn out with the healthcare system because they don't think of her as Jill, the 28-year-old who jogs marathons and camps and goes drinking beer with her friends. And she said, well, first of all, the last time she went to her endocrinologist, she saw the 4th PA she had seen that year. She didn't know if the nurse and the PA and the doctor who came in for a minute were talking to each other. They, she says, and I heard you all say this, have the evidence-based treatment protocol. But she said, what about my life? And finally she said, does anybody in here have type 1 diabetes? And the nurse started laughing and said, my child does, and I get it. And she said that was profound to her, that somebody said, I get it. But my question to you is, who helps people with chronic disease, who know what the management needs to be, stay between the lines and having a real life? I teach medical students. They know what the treatment protocol is, but they don't know anything about the people's lives.
No one. There is no answer to that, actually, and that's why, you know, every opportunity that I get to focus on that, I let people know that it's their responsibility. That is the human factor. And when you go to school all these years, you know, you get all these credentials, we lose sight of that. You know, it's about making your title longer, having more credentials for the evidence-based practice. But the human factor has to be the individualistic source of wellness, and that's it, because you are no longer that. You are the patient with the issues that I can help solve because of my credentials that enable me to be qualified. And so I understand that journey, and that's why I always encourage people to understand that and try to separate the two, because I'm a 36-year-old
yeah,
marathoner, triathlete, personal trainer, fitness. I was all of that before I became kidney failure, needs a kidney. Everybody's focusing on my failure. What about the other elements of my life? And that's what we have to keep in mind. I had a catheter in my heart for 7 months. I was immunocompromised. I still had to take care of my family, be a nurse. How can I do that? Raise a kid, all of these things. So be a woman. You know, I've never had self-esteem issues. Well, guess what? You got one now. You got a kidney. You got a catheter, and you have this 4x4 that's taking over your life. No one ever asked me about that. And then as you progress, you're working towards something. You know, you have to be on the list for so long to even be seen and thought of. Well, in my mind, as a patient, that's my goal. But then you have the compliance issue, everyone with their Medicare assessments and their this and their that, and you can't really express those things, and then you're going to need a psych eval and other meds. So we have to keep that in mind as individuals, who we're looking at, throw this to the side and ask them, how are they doing, and talk about their lives.
I'd like to add on that, you know, talking about the credential point of view, there's objectivity, but then there's empathy. And if you can't have an empathetic point of view with your patients and understand what's going on with their lives, kind of the same way. 29, like going camping, like, you know, going to museums, learning about art history, design, technology. Does my doctor know about that? No, because they never ask. And without thinking about it from the point of view of, well, what are the goals you want to achieve? You know, this isn't an end-all, be-all. This doesn't mean that your life ends. Keep on going, and we're here to help with that. Let's set a plan. Let's put a game plan together to help you get back to that point where you want to be, and let's look at what we can do to make that a reality.
So here's my take-home as a teacher. I want to know if I got this right. One of the things that a doctor can do is to help change their perspective to see you as a person and not a patient is, what's your greatest fear? What are your issues? What are your goals? And then that begins to come out if they'll take the time.
Good morning. I'm Jennifer Dillahay with the Roundtable with the Arkansas Department of Health. I trained as an infectious disease doctor, and I remember reading a study and early on in some of the drug trials for HIV medication adherence, which has been very difficult. And one of the studies pointed out that the factor that seemed to make the most difference was whether or not the patient perceived that the people in the clinic cared about them. And all of you have alluded to that to one degree or another. We were just talking about it, empathy and things. Are there things that you wish that the people you interact with could do differently that would better communicate that kind of empathy that would have an impact on how well you could adhere to the medication treatment?
I'd like to comment on that. I know when we went for our initial transplant evaluation to get onto the transplant wait list, it was like an overwhelming, unbelievably extensive day, and so much information is thrown at you all at once. I believe that taking care of yourself is an ongoing thing. You cannot do it all in one simple meeting, which was done that way, and I'm sure it's done every day today in America when people go through the same thing. And when I questioned the fact afterwards, like for purposes of, I don't understand this, or adhering or moving forward, don't you think that we could have like a mini workshop or an afternoon meeting, open it up, that people could come in and participate and learn more about their condition, the importance of taking their medications, or the importance of why this does this or why that does that. I was shot down. Well, we don't have, that's not my job. So it has to be somebody's job somewhere in the planning. It takes a team of people to manage this disease, not just one person, not just the patient, not just the caregiver. We had a good team, I think, with dialysis when we got there. We had a horrendous experience of being on, I guess, the wait list, because we went through 5 transplant coordinators before, we finally got through to things, actually got onto the list even. It was just, they change over frequently. So I think that there has to be continuity, and there has to be ongoing education, as opposed to a one and done deal. So that's my...
Ruth Parker, consultant to the Roundtable. So I really appreciate you all are so articulate and are all dealing with complex chronic illness and all it means, and you're very articulate about it, which is great for us for really getting inside of it. I wanted to sort of ask you to step back, communicating clearly about medications. Clearly, complex chronic illness and the individual personal experience is so much about that one-on-one communication. It's so easy to gravitate into it. But we're in Washington, and I want us to get above it and look down and say, what could we do that could have a big impact across? And you've touched on a couple of them, and I wanted to sort of push you to think, in that vein. It's a horrible phrase, but building or achieving digital interoperability. You talked about it. If we really had the ability to understand and know what every person's taking and where it is and what that could mean and how that would translate down to an individual level. You've talked about, it's funny when you said care provider, I know we say healthcare providers and we think of the prescribers and all that, but I was thinking of the caregivers on the front line, particularly for really high cost, high need populations, and how you build something that could help as a bridge for people who do have and are living with complex chronic illness, leveraging digital technologies. What are the examples? Who's doing what, where? How do we build on those as part of health literacy, making what it is you need to know and do really accessible, really there, evidence-based, based on what are the real facts. We can give you probabilities related to risk benefits, but we can't give you predictabilities. We can't tell you what's going to happen inside of you. We can tell you the probabilities based on numbers, but what can we do in a health literate system to advance the ability to get to people on the ground through whatever system, through whatever levels they need, good, clear, actionable information about medications?
One of the things that I found to be extremely helpful was, and I find a lot of information, whether it be good or bad, or at least it's a starting point, is within social media. No one's here mentioned that today. And I've gone on to Facebook. I've searched for various groups relating to my son's illness, prescription medications, whatever. There hasn't been a lot that came up on prescription medications, but, you know, once your word got out there, if you establish something there, people sit in that chair 3 times a week, 4 times a week at home for hours on end. What do you think they do when they sit there? They watch TV, they go on the internet. That would be a perfect opportunity or an access point for you to get the information out there and ask them questions to share with them. I think that that would be very helpful. I've used it on different occasions and even shared my information with a lady from the FDA when my son didn't have access to the Next to Me device that's used with his dialysis machine for transmitting data, real time, back to the center as far as his dialysis treatments go. They didn't give, it was being used in other centers in other parts of the country, but my son wasn't given access to that. And it would have made our job much easier and the nurse clinician's job, manager's job, a lot easier, because she would know real time how his treatment was going. You know, that's an example with using the dialysis machine, but I'm sure that with prescription medications, adherence, and education of people, that you should take a closer look at reaching out to that large population that uses the internet and social media.
I'd like to add, you know, social networks are critical. Whether they're forms from, you know, National X Foundation, or even Facebook, even Twitter, those kinds of forums and those support groups are so mission critical because it gives you a voice and it gives you an understanding that there are other people out there like you. Speaking specifically about the mobile health care, this is actually an area that I'm very interested in and I've been working in for a couple of years now and trying to figure out how can we design digital tools for patients with skin and cancer-related conditions. But the thing is that there are a number of these sorts of applications already out there on the market, and that's totally fine. But the problem is, and the challenge of why they haven't become so, I would say, diffused and even popular and more meaningful is that they miss the critical part of being able to integrate with an EMR system and being able to make those records and that data and those data sets accessible to the care provider. It's doable now. There are still challenges. There's still technological hurdles. You know, all the major EMR companies are working at pushing their ecosystems, you know, from Cerner, Epic, Allscripts, and Clinical, to be able to have accessibility and access to these third-party data sets. But it comes down to being able to bridge that gap even further, both evidence-based and making it meaningful. As a good example, too, Humana. I happened to have the opportunity a couple of months ago in Chicago to speak with I think it was their director of innovation. They were looking at their providers in healthcare and Medicaid and Medicare was causing their company to bleed out the wazoo. So what did they do? They went in and they took the time to go in and do qualitative contextual research, ethnographic research on the lived experiences of these patients. And the data that they found, they were able to build smart weight loss, smart scales that would integrate with their care provider, the data, so that they could better manage and track weight loss, which increased outcomes. They've also been working on, you know, things like internal standardizing and condensing their systems, because companies that large have, you know, 6 or 7 different data stores for your records. And so you call, you get one person on the line, your data might partially be in that system and they can't answer your question, so they send you to another department that has a whole nother system that may have another 20% of your records in. And so being able to focus on, from a framework point of view, maybe even from a legality point of view, how do we better create these ecosystems that are streamlined and enabled and encourage these organizations to both open up as well as streamline what they already have so that there's better access and better enablement.
Okay, that's great. What are your thoughts, if you don't mind, on interactive patient systems, like the ability to use that to communicate about medications from a technical standpoint?
Oh, it's absolutely necessary. If you want to talk about outcomes and compliance and adherence, you know, I happen to have a whiteboard in my kitchen that has like when I need to take my medications. But I also take the most, you know, wonderful device that's smarter than what landed us on the moon, you know, and put those reminders in so that I don't forget. You know, I take an immunosuppressant once a month, every 28 days. And sometimes I forget about that. So I set up 3 reminders, one a week prior, one a day prior, and one the day of, so that I can better remember to be compliant, so that I know that if I don't take these immunosuppressants, my immune system's going to go haywire, and that's never fun. So it's being able to even have the doctor to have access to a patient of pushing those kinds of communications are critical.
Good morning. I'm Jane Grover. I'm a public health dentist with the American Dental Association, which is a member of the Roundtable. And as we look at 21st century integrated care, I have to ask, did your oral health community have knowledge and support of what was going on with you systemically? And then on the other side, did your medical community ask or inquire about your oral health status? And as we talk about EMRs that don't talk to each other, the dental world is often perceived as a universe far, far away. Thank you.
I wanted to touch on that. I thought this was Jeopardy for a minute. I was like,
I saw that.
man, the reason being is because one of my first symptoms with kidney failure, you get this metallic taste in your mouth. Understand, I've been a nurse for 20 years. You get like 5% of this education in theory. If dialysis is a specialty, so if you're not renal, that's it. In nursing school, look, they're difficult patients, deal with them, make sure their access is flowing, and keep it moving. That's really the general gist of it. And so I had no symptoms because I am so healthy. There's nothing else going on with me but this. I had pregnancy-induced hypertension, preeclampsia. So I was on 38 pills a day during my complicated pregnancy, and my kidneys gave out a year and a half later. During that time, though, I kept going to the doctor. Everything was fine. But like 3 months before I got diagnosed, I stopped really eating. And I had this bad taste in my mouth, but I wasn't communicating I have this bad taste in my mouth because I went to the dentist and I was just saying, you know what, maybe I have a rotten tooth, maybe something's going on. So I scheduled 2 family appointments for everybody. Coincidentally, my daughter had strep throat like 3 weeks earlier. I was like, maybe that's it. No, it wasn't. And so the dentist said, everything is fine, nothing's going on. And I was like, are you sure? Yes, perfect bill of health and things of that sort. And then I would only find out 3 months later that that's exactly what it was. It was because my kidneys were failing, and that's one of the signs and symptoms. But even when I went back, I purposely made an effort to go back and explain to them why that was. If someone comes in with these issues, what is it that we can do? I've been in touch with Medicaid and Medicare about that, saying that it's mandatory that people should have this incorporated into their plan of care. And I was doing that 2 weeks ago, and I'm scheduled to do that in Springfield. And when I speak to people about oral health, and I make an effort of that, because another issue you have, then you get kidney failure, then you're on dialysis and things of that sort. Well, that symptom never goes away. And in dialysis, dietary is very important, but it's also the reason why we have the highest mortality and morbidity issues, because when you're a kidney failure patient, you have to watch everything you eat, and all of the joys that come from nutrition are taken away, because your kidneys regulate everything, potassium, calcium, phosphates, things of that sort, and Lord forbid, most of the kidney failure patients are secondary to diabetes. So it's that major. So if I don't correct this issue and figure out what this problem is, how can I get that? I'm not going to want to eat. I'm going to lose weight. I'm going to be non-compliant. I'm going to have a different dry weight, which is going to predispose me to more issues with my dialysis. We can keep going, and it's that big of a deal, but nobody is pressing that. So that's my thing for Washington, and I'm the social media person. I tweet, Facebook, I have like 4 pages, like I'm that person. But for what can you do in Washington is encourage that and change this stigma. Your dialysis centers don't allow patients to post pictures. They don't allow you to take pictures in dialysis. Imagine that. I think that's terrible, but I still do it anyway. What are you going to do, take me off my Medicare and my Medicaid? Like, really? But it's that big of a deal because we want this to be a dismal picture. We're not encouraging live donation. We're not encouraging, hey, you can be on dialysis and have a healthy attitude and then still say these are the problems. So I'm just happy to be here. Like on my Facebook page now are 14 medicines I got weaned off of, the side effects and adverse effects of those, and how I came to get to this moment. And if we had more of that and it was encouraged, it would be a lot better.
Dental care was stressed to us throughout our dialysis and transplant journey. After a transplant, we were informed too, in terms of dental care, that prior to any dental work being done, preventative antibiotics had to be taken. And believe it or not, 2 days ago this week, my son chipped a tooth. And I had to call the transplant center. The coordinator had to call in a massive dose of preventative antibiotic before he could be treated at the dentist for that chipped tooth. So yes, there is education there, but it came via the transplant center at one point of education along there. And we, as proactive parents, my husband and I, with our 26-year-old, do follow up and make sure that those visits are met frequently, as well as, believe it or not, a dermatology visit annually. It's because of the high risk of developing cancers, skin cancers. So
Sure.
those are the things that came up.
Thank you.
Hi there, I'm Lori Francis, and I work with federally qualified health centers. I'm also a nurse. And what a great panel. Thanks, all of you. And Terry Ann, this is such a nice convergence for us in the both patient care and human-centric design and thinking, and then also health literacy. And here we talk a lot about us becoming more compliant and literate, right? And so I think that's what you guys are talking about. I always feel like the compliancy lives here with the health care system or lack of system, and the adherence lives here. And so I really, really appreciate your comments. I'm thinking on interoperability. It's, again, us. How do we incorporate the patient's lives, needs, strengths, resilience, fears in our approach first and foremost? And I'm thinking about, I think it was Terry Ann's question, one more time, if you could start again, and I think of Darvis particularly as a nurse, but any of you, like, how would it look at the beginning? How would it look if we met you where you are with what you're wondering about and built your care with you around your goals, instead of us constantly trying to tell you how we would like you to meet our goals?
There was just 2 weeks ago, someone came to me and asked me, they said, Darvis, you know what, how about a child life specialist? And I said, yeah, and I'm thinking to myself, I've been going through this for 19 months. The only reason that people even know who I am is because I stay, as you can probably tell, I'm very proactive about bugging people. I write, I call, I email, I Facebook. You know, it's the only way to get responses, because people are going to shun you away. If I have to see you twice a year, you know, once a year, or whatever the case is, that's all that I'm trying to do. But again, my daughter was 6 when this started. She's 8 now. So if I waited on you and the system, the child care specialist is coming 19 months later. And so if someone would have just came to me, you already had my chart. You knew I was diagnosed. I'm 34. I was diagnosed after a marathon and triathlete with a kid in tow coming from Chicago to Las Vegas. If someone would have just looked at that, and then you keep seeing me, but then we're working you up for a transplant. No one ever said, how's your daughter doing dealing with this? What can we do? Here are some resources. My first year going through this, I was so poor. I went from being a nurse supervisor, you know, making a healthy salary with great insurance, to now this. I had no money for my medications after living off of my savings, losing my job because now I can't work 12 to 16 hours with my legs swelling up, all of these things. And here I was, a nurse in tears, communicating to people, trying to get them to understand, I'm on dialysis. This is a big deal. I need a transplant. So people could not even see me for anything other than my diagnosis, let alone that. You have to meet people where they are, instead of focusing on where you need them to be and where they want to be. Imagine the pressure involved. I mean, I was so depressed and everything, and it was my fiance that kept saying, listen, you have to go to your appointments and dress up, put on makeup, comb your hair, like, get it together. And I couldn't do that at the time. But he said, people are looking at you, and you need a transplant, and they have to know that you're doing okay. Because if you look like how you feel, you're not going to get the transplant because you're not going to get the medications because you can't afford the medications and all these things. And that's why, once I got my organization together and built my brand, every day that I wake up, I have to be the poster child for renal. There is no hope in renal. Diabetes has a month, breast cancer, but think about it. How many dialysis patients do you know that you can go and tell somebody, she looks darn good, and she does this, and she still does that, and he does this, and it really doesn't happen. Post-transplant, pre-transplant. Meet the people where they are instead of focusing on where you want them to be. And explain to them, you're all covered with this good stuff. Now let's get to the real you. And so that they don't feel that they have to decide,
And I think that you need a roadmap. You need a plan so that one thing that I really wish is that I would like to know kind of what might be next. Even I'm not saying it's going to happen, but I'd sort of like to have that in the back of my mind, and I didn't find that anywhere. I found that I was the one that always had to ask the questions and find out, and then set my own plan into motion in my mind, what might or might not happen, and ask questions. I really think that there's a great void there, and I think that you can do wonders with that in terms of medication. Say, well, these medications here, this adherence here, if you do this, if you don't do this, this is what might happen. Just to have it laid out there somewhere as a resource for somebody to turn to. It might not solve everybody's situation, but it might help a percentage of the people out there.
Just to add my bit, building off all of this, it's the acknowledgement that life does go on, right? That you to Darvisa's point, meet you there. If I had been told when I was 19 that dark times they are a coming, as my mom would say, that if I would have known that being put on methotrexate, being put on Raptivo, an immunosuppressant no longer on the market, UV therapies, and all these other steroid creams and steroid pills, that in 2 months you would have been trying to live at a distance while going a sophomore at college, you get radically depressed. I lost 30 pounds in 2 months just from trying to deal with the medications. I couldn't eat, couldn't do anything. It was a challenge. But being able to, luckily I had a really great dermatologist who, worked with me on that and said that, if, to your point, if you show up, you have to show up for yourself. It doesn't get any better. It only can get worse. But it's only when you define what rock bottom is and how you want to show up and make your life more meaningful and more helpful and more, valuable to yourself, that being able to be told that is so paramount. There's the psychological effects, the social effects are so critical that we miss the boat on that all the time, quite frequently.
Really quickly, the name of my organization is More Than Your Kidneys, and the reason that it's called that is that's the name that my fiance came up with. And that's because we were having a passionate argument one day, and I was telling him this is the mindset of a renal patient, and I was like, why don't you know what my current creatinine level is? Why aren't you tracking with me how fast it's falling, when I'm going to have to be on dialysis, when I could possibly get a transplant? All of these things that they embed in you to know. This is your calibration and litmus test, so to speak. And he said, listen, it doesn't mean that I don't love you any less, but I'm not going to be bombarded with the norms of your new world with your new kidney, because that's all you think about. But you're so much more than your kidneys. That's nothing. That's just your diagnosis. But it's up to you to figure out what type of life you're going to live, and this is the moment to redefine yourself. So when I go and speak to people, I let them know you are more than your emphysema. You're more than your COPD. You're more than your diabetes, because that's what you focus on as a patient. You have this great wealth of knowledge from these wealthy people that are qualified to tell you these are all of your problems, but nobody is focusing on what else there is, and that you're so much more than that. Let me get to know you. And so people, I get most of my people and that I help from doctors and pharmacists and everybody referring them to me, because you're more than that. That's just your problem. Go to someone, go to a resource and find a solution, and you'd be surprised. People actually do want to talk about it. They actually want to give you the information that you need to comprise your realistic care plan. That's it.
Hi there. So before Bernie brings out the hook, Wilma Alvarado Little, member of the Roundtable. Again, thank you very much. This has been a wonderful, wonderful panel. And what resonates with me is the issue of empowerment and advocacy and being that patient that keeps asking the question. And so my question comes from, and perhaps this will be discussed later, but I'd like to put this out there. What words would you provide to parents, speaking from a pediatric perspective? What words of guidance or support, or, if you best get in front of this by doing blah, blah, blah. So coming from an organization that is pediatric subspecialty facility, what words would you provide parents who have to advocate from a pediatric perspective?
I really think that having a good support network, maybe support groups, that kind of thing, in terms of the deal specifically with pediatrics, because that's a tough one. I mean, you're dealing with little kids, a terrible disease, and it's so young in their life that they're going to have to, go through it. And from my understanding, in kidney disease too, it's like a separate thing all the way around. Like, they deal with the pediatric patients very, very differently than they do the adult patients. My son's case, he was 23 whenever this all started happening to us. So he was beyond the pediatric. But you know what? Pediatrics came into play when we had to find out what might have caused this kidney disease, which, by the way, they never did. So we had to go back to the pediatrician that he had as an infant, and they had to go back to the little man in the mines and pull out all those medical records. So it is crucial. It is a component, medications, infections, things like that he had throughout childhood, to try and determine if that had an impact of what happened with him later in life. So yes, it's a really tough thing, and I think support groups and networks out there specifically geared towards the pediatric patient would be important.
I see Rob standing here. I definitely would like to have him before we conclude. Rob?
I'll be brief. Thank you. Rob Logan, National Library of Medicine. Let me close this on a positive note. There really are medical centers in this country that specialize in listening to a patient's lives and journey. They make it integrated into clinical care. I'm thinking immediately of the South Central Foundation in Anchorage, which specializes in that. Okay? They call it the NUCA system of care. I've been through the training twice, and I remember one time I was with the training, John Berwick, who used to be the head of CMS, turned to me and he said, I really wish this place was the rule, not the exception. He said, but again, they're really, and they are not alone. They can certainly tell you other places that have done things very similar to them. But many of the things that you discussed, okay, they are definitely in process, in place, and make significant clinical differences where they're done, okay? And I wish those places were the model, okay, that were utilized throughout the U.S. and in other countries around the world.
Well, thank you, Rob, for that, and thank you for the Don Berwick comment. It always reminds me of Don Berwick gave a commencement address at Yale University at the graduation of his daughter, and he gave the usual inspirational speech, but at the end he said to the graduates, he said, take off your white coat and sit amongst your patients or your group, and you'll really get insights as to what you need to know. So that's what I think I heard a lot today from the panel. I want to thank Terry. And I definitely want to thank the panel members, Caleb and Bobby and Darvis. You're the most articulate and the most impassioned group that I've heard in a long period of time. And activated. Not only are you personally activated, but I'm sure you activated the group in front of us. Your insights, your advice, how to better communicate and encourage patient and family activation to achieve better outcomes, and it is a lot about patient and family activation, and enablement. Caleb used that word, enablement. I think that's really a key in moving us all forward. and your advice to the caregivers. I think that's a critical element, being one of those, to focus on your needs. We need your continual voice, and it's your kind of voice that makes us all better in improving our care and improving our outcomes. It's true that technology, and it's true that data and social media are really critical elements here. But, I'm going to use but, personal involvement, concern, and communication remain the key elements in your recommendations that involve specifically vulnerable populations. And vulnerable populations can mean many things, socioeconomic, but it can certainly mean people who are, have chronic illness and chronic disease. So thank you once again. This has been a terrific panel. We all learned a bunch, and we'll try to keep the voice going. Let's take a 15-minute break, 15 minutes, and be back right here, and we'll start with the next section.